Hello, everyone, and welcome to the Testing Psychologist podcast. I'm your host, Dr. Jeremy Sharp, licensed psychologist, group practice owner, and private practice coach. Many of y'all know that I have been using therapy notes as our practice EHR for over 10 years now. I've looked at others, and I just keep coming back to therapy notes because they do it all. If you're interested in an EHR for your practice, you can get 2 free months of therapy notes by going to thetestingpsychologist.com/therapy notes and enter the code TESTING. This podcast is brought to you by PAR. The Neuropsychological Assessment Battery offers the combined strengths of a flexible and fixed neuropsych battery. And now you can score any of the NAB's 6 modules on PAR iConnect, PAR's online assessment platform. Visit parinc.com/NAB. Hey folks, welcome back to the Testing Psychologist. I'm thrilled to have a guest today talking about a topic that we have really not talked about much at all on the podcast, and that is designing a practice around older adult neuropsychology. So I am honored to have Dr. Seda Terzyan here to talk to me about her practice in Orange County, California. So Seda is a neuropsychologist and founder of Perspectives Psychological Services. She has her doctorate in clinical psychology from Loma Linda University. Her training emphasized both evidence-based treatment and differential diagnostics through neuropsych evals. During residency, she worked in private practice settings across the developmental spectrum with children, adults, and older adults. And her group clinic is currently specialized in working with geriatric populations, providing both diagnostic evals and treatment for medically and psychiatrically complex populations. So, as you can tell from the title, we primarily talk about Seda's journey in building this practice around older adult neuropsych services. So we talk about just older adults, working with them in general. We talk about some of the considerations there, the topics that are most meaningful for older adults, and primary recommendations for older adults during the evaluation process. But we also spend a lot of time on the private practice component. So we talk about just basics and how Seda got her start and really got the train moving with referrals and business in the practice. We talk about the practice environment and accommodations, choices she has made to specifically support older adults. We talk about hiring and recruiting and finding good folks for your team when you work with this population, and a number of other things. This was really illuminating for me. We primarily focus on kids, but have older adult services as a component in our practice. So this was a fantastic conversation. And I did not explicitly ask in the interview, and want to make sure to mention that if anybody enjoyed the conversation or want to connect with Seda, you can check the show notes for her email address and make sure to reach out if you want to connect, talk about the practice, or are even interested in working with her. So without further ado, let's talk about older adult neuropsychology with Dr. Seda Terzyan. Seda, hey, welcome to the podcast.
Thanks, Jeremy. I'm really excited to be here.
Yeah, me too. We have not done a whole lot of content on adult neuropsychology, as longtime listeners will know. So yeah, I'm really excited to have you here so we can dive into that area a little bit. So grateful for you to be here. Thank you.
Thank you.
Yeah. Well, we'll start with the question we always start with, which is, why is this important to you? I know it's a big area, adult neuropsychology, and we can drill down within that. But yeah, why spend your time in that area of practice?
Yeah. Honestly, it's, I think for me, I fell into it mostly with therapy. I just really enjoy working with adults in therapy. I've worked with kids in the past, but I have more of an affinity for the type of therapy I do seems to go better with adults. It's a very different world with children, but with neuropsych particularly, I just think there's a big need, especially with geriatric neuropsych. with the aging population and mild cognitive impairment becoming so much more in the forefront with research and everything. And the more we learn about it, the more it seems if we catch it earlier, we can actually intervene and really help people change their lives a little bit more drastically so that we can avoid those more severe consequences of dementia. So I'm really all about let's get people tested earlier, more often, and neuropsych is at the forefront of being able to do that effectively. You can get an MRI and it could look great, even if you potentially have dementia already. So it's misleading at times. So it's, imaging techniques don't necessarily do the job that neuropsych does in finding these subtleties. So I'm really passionate about that and just helping people with managing their cognitive health, emotional health, and it's all really intertwined together.
Yeah, yeah, for sure, for sure. I know, a lot of us, I think, pursue areas that are personally relevant for one reason or another. I've found, like, I've always been a kid person,
Yeah.
kids and teens, but now that my parents are getting older and are having some cognitive concerns, I do find myself like my mind is drifting a little bit to like much more interest in adults or aging,
Right.
neuropsych kind of stuff. And I
Mm-hmm.
don't know if there's any of that for you, or if you just find yourself drawn more to adults, versus
Yeah, like I
kids.
said, it was a bit of a draw just to the adult population, just because that's where I enjoy and really feel active as a therapist. And
Hmm.
for me, I've always been a therapist first, and neuropsych has
Mm.
come after. So that's what
Mm.
got me into that world, I think, more so. And then I really got interested in evaluations. But I will say, just on a cultural level, I'm an immigrant. I was born in Ukraine. My dad's from Armenia. So it's a culture very much, I'd say, organized around. The elderly are a very important part of our culture, and I've always respected my grandparents. And a huge part of our culture is always helping the older generations. And coming here, my parents didn't even speak English, so my sister and I were very much involved in helping with translating and this and that. And as they age, I'm just really I do find myself having a warmth to these older people, and just wanting to take care of them. It's just the world is changing pretty drastically, and I think as people age, it just gets more and more confusing whether or not whether you have dementia or not. So I think I just really enjoy creating a space for them to come and really help them understand the process and work with them in a way that you know helps them still feel independent. And I'm really, that's very important to me. I really want people to hold on to their independence and not just get you know you see it often where the children start to just make all the decisions for their parents, and it's just easier that way. But I think it's really important for people to keep their independence, because that keeps you sharp. It keeps you more cognitively involved in your life.
Right, right. Like it's a two-way relationship, I would imagine,
Right.
like
Hmm.
staying more independent helps keep you sharp, staying sharp
Right.
keeps you more independent.
Right.
Yeah. Yeah. This really resonates. I don't know. I mean, I think it's just a function of where I'm at in my life and, getting a little bit older myself and, a little existential dilemma here, but also, aging parents, and all of my
Yeah.
grandparents have died at this point, and, seeing some of them go through that process. I've been thinking a lot about the idea of aging with dignity and what that looks like. And just, I think, struck by the potentially important role we can play in that process. I mean, you can speak to that a lot better, but I've been thinking about that a lot myself.
Yeah, I agree. I mean, what comes up for me is what I was just talking about is I think families are so important when working with older adults. It's actually a little bit similar to working with children, right? You're
Hmm.
always working with the family. I think family education is so important. So when I work with the patient, the older person, and then their children or whoever is helping and is part of the family unit, just educating them on what the person's going through, what they need, and what they don't need. Like I said, I think it becomes this sort of, it's easier, it's faster to just get things done for the person, kind of take over. But like I said, that sort of takes away that dignity piece. And I find something I really hate seeing with older adults is they just get quieter and quieter and quieter, just sort of start
Mm.
pulling back. Um, and I just think that doesn't, I don't think that has to happen. I think there's just so many ways to maintain that level of independence, even if changes are happening. But to maintain a stimulating life is so important, and I think social connection is such a big part of that. And it's not just like basics, like, oh, you go to the social event. I mean, it's better than nothing, but truly what the research shows is social connection, like involvement in your community and your family, feeling like maintaining an important role. That is what keeps people healthy emotionally, cognitively, to really keep that connection strong.
Sure, sure. Yeah, yeah. These are super important ideas. I mean, I think we're going to touch on a lot of different aspects of this work as we go along. But
Right. Right.
um, yeah, just framing it and putting it in context. And our population is just getting older. I mean, there are a lot of folks who are going to need these services as time goes
Yeah.
on.
Yes. And I think it's important to note. I do think some people pathologize aging. Like, of course, I do accept it is none of us make it alive, I guess, right? So
Yeah.
we none of us make it out alive, but aging does not have to be like this disease process. It isn't normal to, it's not typical aging to develop dementia and all these things. And aging can be done, I believe, with dignity. Of course, there are things that are out of our control, but there are just so many ways to intervene early and really just, it's all about education out there, right? To really inform people of what's the most important thing to maintain that cognitive health and emotional health.
Right, right. Yeah, I mean, since we're talking about this, I want to talk a lot about your practice, honestly, and just how you've built that and developed it. But we're really diving right into almost like recommendations, I suppose, at the end of an eval, and I'm willing to just go with this for a little bit.
Yeah.
I'm curious. Yeah, I mean, since we're here, um, there's a lot of nuances to the battery and the testing and everything. I don't know that we like want to get in the weeds with that necessarily, but as far as recommendations, yeah, and how you are working to support older adults as they, as we finish the evaluation and they kind of move on into the community. What are the kind of high level, big picture things that you're thinking about?
Yeah, I think, I mean, obviously it all depends on each person. I mean,
Of
some older
course.
adults, but I'd say overall, one of the big things I like to do is I always like to involve the family in that process. So to make sure the family has a really good understanding of what's going on for the person, what we want to help create for the person, because I do think the family, for the success stories that I've seen, the family's been more involved and much more open to helping the person make some changes. I'll say a really big thing I find myself recommending is to help develop more of like a healthy routine and structure, because again, I find that it sort of diminishes with age, especially as people retire, lose social connections, friends are dying, and like their world, it starts to shrink down. And I find there's this change that goes towards more passive activities rather than active. So you'll see people, they'll be spending more time watching TV and just doing
Mm,
these types of activities that just sort of pass the time, I guess. And what I end up recommending, kind of the main thing, is let's kind of create a structure where you have a morning routine, you have an afternoon routine, and an evening routine, just kind of high level, and then really working to identify just kind of those pillars of health. Like, are you exercising? What is your diet like? Making sure, are we eating at at consistent time throughout the day? And then again, incorporating that social piece. So sometimes I'll work with families to say, hey, can you guys just set up a time once a week or twice a week, so the client knows, I know we're all going to have family dinner once a week on these days. And it's just something you just learn is going to happen. That consistency is really good for people that are struggling with some cognitive changes. And then, of course, it's support groups. I'll find support groups in the area. A few of the community hospitals here have some good resources. Some people are more willing to do that, some aren't. I'll say the senior centers also have a lot of good programs. If you could just get people past this kind of, some people have this block around like going to a senior center, or like what is, so just introducing them to like, really, it's just a place where people like network and hang out and do things.
right, right.
And once people kind of get past that initial whatever stigma, it can really get them going and reconnected in their community. Um, Another big challenge is, if people have any kind of mobility issues, I've noticed a lot of older people really resist using walkers. They'll try to keep using their cane as long as possible, even if it's creating significant limitations for getting out in the world. So this has just come up so many times now, but we'll sit through and really talk about like the pros and cons of why don't accepting and using the cane just to be able to get to the walker just to be able to get out there more, versus again fighting these stigmas around aging, which it's amazing what I've seen. The people will really just not go out there, not do things just because the stigma is just so strong around being out there with a walker. So
I would imagine that's where being a therapist first comes in
yeah,
really, really handy, because that's just like loss of identity stuff,
it
right?
is. Yeah,
And self-esteem, and who are you without, there's just so much wrapped up in that, and
yeah.
being able to support people through that, I think, would be crucial.
There's so many identity shifts in aging. I think retirement's one of the big ones I see often. That's like one of the first hits. And then there's like a series of others that follow. So the way people deal with the adjustments, I think everything in life ends up being like an adjustment disorder. uh, However you adjust determines kind of where you're at. But there's a lot of them that hit people in the later years that we sometimes forget about. There's a lot that emotionally and mentally has to be coped with. It's not just, oh, people are developing dementias or aging. It's also a lot of these stressors that are coming, and how people are responding to those makes a big difference.
100%. Yeah. I don't know, as we talk about sort of recommendations and keeping people healthy as long as possible. I think about that book, Outlive. I don't know if you read
Oh
that or
yeah,
heard of it.
I've heard of it.
Hmm.
I haven't checked it out yet though, but yeah, I've heard of it.
Yeah. Yeah. Just this concept of, he calls it health span. So it's not just lifespan, but health span, and the three
Yeah,
pillars of like, it's basically relationships and diet and exercise, and
I
just
mean
making sure those are dialed in.
it does. It sounds like so simple, but it's not as simple as it sounds, right? In reality, to make all that happen, it's
Mhm.
really difficult, and that's what these things make it sound simple, but to me it comes down to how are we in our lives day to day. How do we take care of ourselves? What's our relationship with ourselves is really what determines it. Interestingly enough, I went to Loma Linda University for graduate
Mhm.
school, and we're actually Loma Linda is considered a blue zone in the U.S. for people
Oh,
living like into the hundreds.
uh-huh.
And I was involved in a study there, with professors doing research studies. There's a lot of people do research on that population. And yeah, I mean, again, it comes down to a lot of studies are trying to differentiate what are the factors. So there's a lot of Seventh-day Adventists in Loma Linda, a lot
Hmm.
of community around the church.
Hmm.
So people tend to keep these strong social connections alive.
Hmm.
Um,
Hmm.
and interestingly enough, Seventh-day Adventists are vegetarians, and they don't drink caffeine. Many of them don't smoke, drink. So all these health things are well controlled in this population, and lo and behold, they're living extremely long and healthy.
Right. Right. Yeah. And we play a crucial role, I think, in helping folks go down that path if they want,
Right.
if they want to.
Yeah, and
Yeah.
I just think emotional health is such a big factor in whether or not people will take care of themselves, like whether
So
or not
true.
people will exercise or eat right. If you don't like yourself, on a basic level, or you're just so stressed out, the last thing on your mind is I need to eat right, or I need to take care of my body.
Sure. Of course. We have a neuropsychologist in our practice who works with older adults primarily, and she talks about the just immersion in conversations about existential angst, and dying and losing people, and so forth. And I wonder if that's true for you as well, that these
Yeah.
are just topics that you get comfortable with as someone who works with older adults.
Yeah, I mean, I think you have to be. In a way, honestly, I think you have to be no matter what if you're a therapist. It comes up
I
just as
think you're
often with
right.
my younger people as it does my older. If anything, strangely enough, I've had a lot of experience with older adults, where they'll talk about their mortality in such a matter of fact way that it almost makes you feel like anxious, because they're so at peace with it. So there's an interesting thing that's what I've noticed more so that's striking is a peace with it for some, not all. And if some of them, just a welcoming, because maybe a spouse has passed, maybe and they're just like, I'm ready. And I think some clinicians could confuse that as suicidality. And you do have to be careful with this. But I
Of
don't
course.
see it as that. I think it's something very different. And I think it, on some level, does start to make sense. But, eh, helping them find purpose now is so
Hmm.
important, right? Rather than, it's like you're checking the clock for when you get to leave. That's not
Oh,
healthy either.
right, right. Yeah,
Yeah.
it's a fine line.
But
It's a
it
fine
is
line.
somehow, it's almost like I've had more experiences of the opposite end of it, where the older are a little more um, sort of looking forward to it in a way, in some cases, not in a depressing way, but they've come to an acceptance, which I think is not a bad thing. Whereas I have younger people that have, extreme angst about, what if I die? What if, um, who's going to take care of my kid? Just whatever issues I see more often in my, I guess, middle age adults. I see that more.
Yeah, yeah, yeah. It's relatable,
Yeah.
but not about me. Let's pivot to your practice a little bit. I would, love to hear some of the ins and outs of building a practice around older adults and older adult neuropsychology. So, can you just? I would love to hear just like the brief, bio of your practice. Can we start there?
Sure, sure. I'm trying to think of where to really start, but I a lot of my experiences through practicum, internship, they all ended up in the adult realm. I've had a few pediatric experiences, um, and on postdoc, I worked with a lot of um, geriatric patients. So that happened to be the population at that time. Also, at Loma Linda, I did work at Loma Linda Hospital on their rehab unit, and again, just ended up working with a lot of older adults with, dealing with not only an adjustment to whatever trauma they've just gone through physically, or stroke or TBI or something. It ended up being a lot of older adults. So that gave me that was probably my big introduction to that world of really working with families, helping older adults navigate, and help making sure they're understanding, making sure they're making decisions and they're not being, for good or bad intentions, from being influenced too much from their family, whether well intentioned or not. Just trying to, I became very aware of that at that point, of how important that is to make sure they understand and they want to do it whatever way they want to do it. So on postdoc, I did more outpatient. It was all outpatient, and we got a lot of our referrals from neurology. So that's where I kind of realized neurology and neuropsych have a lot of overlap, in terms of the patients we
Yes.
see, the conditions we treat. Um, so once I was licensed, which was actually kind of during my postdoc experience, I already started to, um, I started to see patients, so I found a little space. I am living in Orange County. So I found a space, I think it was in Corona Del Mar, actually. I found one little office space. It's great, really nice. I loved it, but it was tiny. Um, and I started seeing therapy patients. It was just easier to start as a therapy practice. Neuropsych has a lot of, materials and things,
Mm-hmm.
expenses involved. So
Hmm.
as I was seeing therapy clients, actually started seeing therapy clients just from Psychology Today referrals, and I was
Hmm.
already working at other practices, just doing some contract work. Um, and as I got my own space, I kind of transitioned there, and some people followed, and some people didn't, and that's just how it works. But Psychology Today actually was a great resource for me starting out for therapy. So I did get a lot of referrals just from there for therapy clients. Um, but I really wanted to build the neuropsych side. That's what I wanted to do. I wanted it to be a neuropsych practice. Um, so it was, I guess in retrospect, it seems serendipitous how things happen. But if I think about it, there was a lot I was doing at the time to kind of
Hmm.
position myself for these encounters or meetings with certain people. But I even joined a BNI, Business Networking and International group. So I did
Sure.
that for a few years, just kind of trying to get, entrenched in the community. And it ended up being a really cool experience where I wasn't working with other psychologists and neuropsychs. It was just, real estate agents, attorneys, but just learning. It was a really cool experience to just do that. But through all these efforts, I did meet this really cool neurologist who at the time had a practice. I believe it was Mission Hospital, a small outpatient practice. And he just said, I really have a lot of patients that need neuropsych, and I don't know anyone to refer them to. So I just came in like in-house and started doing neuropsychs for his patients
Okay.
um, as like a contractor. So
Yeah.
I started off there. I already had my practice doing therapy. And through that, I think it was about a year or so that I did that. As that practice was closing, there was another neurologist that was working there, and we were there on off days. So we never actually met, but he saw some of my reports. So as we were kind of leaving that practice, he said, "Hey, I want to send you more patients. Um, are you seeing people?" And that's kind of that I define as like the point where it really started, the neuropsych side. So this doctor started sending me referrals. I started actually getting rather full, and I very quickly jumped on getting credentialed with insurance. So that's where that really started, because this doctor's like, I have these patients, but they want to be seen through their insurance. And I already knew this, but that was really kind of the fire that was like, I need to get paneled with some insurances just so I could see these patients. So I did. I got with Medicare and started to work on these, hospital HMOs. He helped me introduce me to some people at certain hospitals in the area and got medical staff privileges. And it sort of just started taking off. I will say the insurance, I knew I was going to take insurance, but it was at that point that I really kind of got on it. And and the reason is I just had experienced, even on postdoc, when you're getting referrals from medical professionals, when you don't take insurance, it creates a really difficult bridge to cross for patients. Especially when, I think we talked about this a little before, but especially with geriatric referrals, the testing that we do isn't necessarily for the patient. It is,
Mm.
but it's really a referral question. Our I'm serving more so the neurologist. The neurologist
Hmm.
wants to know, hey, what's going on here? So they're
Hmm.
sending the patient for an MRI, for an EEG, and for neuropsych testing. So we're just one of those specialty stops for the patient. So it doesn't even necessarily make as much sense in this field to charge the patient directly, because
Hmm.
it's such a specialty report. Now, I write my reports to serve the patient 100%, with the recommendations and all of that. But I guess that's just kind of how that works. The patient sometimes is like, why do I even have to do this? It's a different vibe from when I worked in a pediatric um, outpatient unit, and they're coming to you, the parents are coming, they want to know. It's a very different interaction.
That makes sense to me. Yeah. I mean, that's an interesting perspective that we're serving the provider versus the patient, but I get where you're coming from. And you live in this world more than I do, but even doing consulting, I haven't found any older adult neuropsych practices that don't take insurance. It just
Yeah,
seems
at least
really,
Medicare. I mean, it
really
would be
hard.
difficult. Yeah, it would be difficult.
Right.
I don't know how they would. I think therapy is a different animal, like that's different. You could probably build a practice for any age range for therapy with, without insurance.
Hmm.
But for neuropsych, it would be very difficult.
Right. Right. So I want to go back and just kind of put a fine point on the getting started part, where it seemed like these neurologists played a pretty huge role in launching your practice, so to speak, and
Yeah, and
just
I guess
making
me
sure.
seeking them out, right? Like I think when I acknowledged that that's the connection I wanted, I started putting myself in those situations just because they were already ingrained in the medical system that I was sort of striving to get integrated into. And that's such a big goal I still have, is just to have more of like this seamless integration. So it's not like medical and then mental health, that we're all sort of intermixed, which
Mm,
I think is how it just should be. I don't think there is no difference between mental and physical health. They're one thing. So,
agreed.
and I like collaborating with people, especially people in different, interdisciplinary. So I just think it's really fun.
Well, and it's just nice to have the full picture or as much of the picture as you can,
Yeah, it
right? Like
helps.
we
I mean,
only,
because I have access now to, the note like Epic, like the hospitals use Epic. I get access to that. I could easily find MRIs that they've done, and all this testing, all that. So it's all just like there, and it's so nice to have all the information. And the patients love that too. When they come in and you actually know who they're seeing and what they're diagnosed with, what medications they're taking, and it just makes the process so much more like connected.
absolutely, absolutely. Yeah, you mentioned the hospital privileges a little bit ago, and I wanted to ask you about that. One, just from a business development standpoint, but also because I am so jealous because we have such a hard time getting records from people. And,
Yeah.
I would imagine being plugged into the hospital system has some real advantages. So I'm
Oh yeah.
curious, just for anybody who might not know, and I kind of include myself in that, like what exactly does it mean to have hospital privileges in this context? And how did you make that happen? Let's take a break to hear from a featured partner. Y'all know that I love therapy notes, but I am not the only one. They have a 4.9 out of 5-star rating on trustpilot.com and Google, which makes them the number one rated electronic health record system available for mental health folks today. They make billing, scheduling, note taking, and telehealth all incredibly easy. They also offer custom forms that you can send through the portal. For all the prescribers out there, Therapy Notes is proudly offering e-prescribe as well. And maybe the most important thing for me is that they have live telephone support 7 days a week, so you can actually talk to a real person in a timely manner. If you're trying to switch from another EHR, the transition is incredibly easy. They'll import your demographic data free of charge, so you can get going right away. So if you're curious, or you want to switch, or you need a new EHR, try Therapy Notes for 2 months, absolutely free. You can go to thetestingpsychologist.com/therapy notes and enter the code TESTING. Again, totally free, no strings attached. Check it out and see why everyone is switching to Therapy Notes. The Neuropsychological Assessment Battery, or NAB, is a comprehensive instrument offering the combined strengths of a flexible and fixed neuropsych battery. It lets you administer the full battery, any of its 6 modules, or individual tests. And now the NAB modules are available for scoring on PAR iConnect, PAR's online assessment platform. Learn more at parinc.com/NAB. Let's get back to the podcast.
Yeah, it's kind of complicated. So I'll use the easier example. So we provide neuropsych consultation inpatient services at St. Jude Medical Center. That's in Orange County. So that is how that first connection kind of happened. And because we had to have privileges to work inpatient, and they needed that, they don't have a neuropsych in place, so they're contracting us to do that service. Basically, you go through this. It's like a credentialing process, like anything else. So you go through a credentialing process with the hospital, but we obviously had this purpose. We wanted to serve. We were asked to serve this inpatient population. So yeah, you just go through the whole credentialing process, but obviously, we had someone that was inviting us in. So I'm not quite sure how that would work if you can just apply to be medical staff or something. It's I'm not sure how that goes, but yeah, it's really just a credentialing process, and then you get the privileges that you need. So if it's inpatient privileges with other hospitals, I have the privileges aren't that specific. So it's just I'm considered medical staff, and I'm able to take patients on their HMO, so I can see patients that are credentialed with that hospital, so I can see them with that. And you just get other privileges. You get your badge. You have some access to the hospital. You can go to the cafeteria. That kind of thing. I don't have admitting privileges. There are obviously, if you're a psychiatrist, you would need that. But it's things like that you would get. Yeah.
Gotcha. Okay, so that does sound so. We have done some work with an outpatient clinic that's affiliated with a local hospital, and a very similar process. It's the We were also invited in, though, and that
Yeah,
sounds like
exactly.
a crucial part of this. And who was it that invited you, so to speak?
So I had actually done some work with St. Jude before on postdoc. And so I had been acquainted with some of the people there, and they had then found out that I had an office that I'd set up in Fullerton, which is very close to the hospital. And it just, it became this kind of connection that was made. And are you doing this? Are you able to do this? And it just sort of happened from there.
Great, great.
Yeah.
So thinking about, I mean, it sounds like you've got your hands in a lot of different things, even though it's all around this theme of older adult neuropsych, right? So, would you say that most of your referrals are coming from neurology and other kind of medical folks, or is there another main referral source for older adults, or what?
Yeah, I'd say that's our main one. It does tend to come from neurologists. And I will say probably the second popular is just primary care doctors
Yeah,
that are sending
yeah,
people because they're kind of the first line of, they're the first ones really that see if there's some issue and people are saying, I'm concerned about my memory.
hmm
Um, Usually, I don't think it's neuropsych is out there, but it's not as well known as like if someone has a memory problem, send them to neurology. And so I find what
hmm
happens is primary care will send them to neurology, then neurology will send them to us to get the clarification. But sometimes they'll come from primary care directly. Um, we do get just adult referrals as well. A lot of those come from psychiatry or people find us themselves. I get a lot of requests for ADHD, adult ADHD testing. That's
Sure.
a really popular one right now. Um,
Yeah, it
and
sure
another
is.
one that I've seen quite a bit of, and that's from neurologists or primary care as well, is people with long COVID, cognitive
Yes.
fog and all of that. So that's actually a really sad, interesting population. But we've had quite a few of those come through.
Yeah, yeah. Same here. We're starting to see those pick up as well.
Yeah. Yeah.
So talking more about your practice, I mean, I love the origin story, and it's like a lot of us, I think it's this combination of kind of being in the right place at the right time and then putting
Right.
yourself out there and like having the skill and it lines
Hmm.
up. But you took the leap, right? And now you have a group and it seems like you've been really deliberate about building this group and creating a certain vibe to
Yeah.
serve this population in particular. Can you tell me about that journey and how you took the leap?
Yeah. Yeah. The leap, God, I don't even know. It was just, it didn't feel like a leap at the time. I feel like I was so like careful, like, okay, now I could get this space. Now, so
Hmm
it felt very careful. But yeah, I mean, I agree, it was a leap. And then it felt like a flood. And then keeping up with the flood that's happened.
hmm
And just to me, it felt almost like the train started moving and I was on the train.
Sure.
It had that feeling. I'm almost trying to slow the train down just to get oriented to what I'm trying to do, right? So it doesn't get too much control. But I will say I have always felt very intentional about what I wanted to create in terms of the client experience as well as like the provider experience. And I
hmm
think that a lot of that happened just based on, a lot of my experiences coming up in the field. Um, I always think of this time where I was like doing these evaluations. They were not, they were long evaluations. I feel like everything in grad school is like these massive comprehensive evaluations. But
Always.
I just remember, and it's so unnecessary, but that's what we did at that time. Um,
Uh-huh.
we were literally, it was like a storage closet. It was this tiny room, just with stuff everywhere, no windows, and it was just so uncomfortable. Like, why would we do? Like, I'm like, I never want to do this. And so many of the
hmm
experiences were kind of like that, and that was the same for therapy as well. I'm like, how could you
hmm
do work like this? You know, in
I
this
get it.
space?
Yeah. Yeah. I feel like it
So
must be a conspiracy of some sort between graduate program. Like our doctoral program was in the basement of this
yes,
cement block building and it was tiny, it was cold, it was sterile. And I'm like, what are we doing here? This is a terrible metaphor if we're trying to, take
yeah, and I
people
was
to
just always
better
so
place.
struck by that. I'm like, we're in this field where we should know better, I guess, than to put people in this environment. Um,
Hmm
I don't know. So for me personally, the environment always had an impact. I mean,
Hmm.
you get through it. You're in survival mode. When I look back, I'm like, I'll get through anything. I got to get this done. And you don't notice necessarily at the time. But, when I look back, I'm like, I really don't want that. I don't want to, that must not have been good for anyone in the situation.
Yeah. Yeah.
Um,
Just
so
like
yeah, I
many
think
other things
that's
in grad school. We just do
exactly,
it and don't
exactly.
question it.
Gosh,
Yeah.
it's sad. I mean, I have a lot of thoughts about that too. Why are we doing that to our future? Creating this unnecessary stress. I think there's just a better way to do it. But
I
I,
agree.
yeah, I think just on a basic level, that was one thing. I'm like, I just want to create a space where the providers come to work and they feel like healthy, and there's windows, and they don't feel like they're kind of like in this stressful, like I have to see a million patients today, or I don't know, just all this stuff that I feel like was not conducive to the work we do. Again, this is my experience, but I don't do well personally if I see too many people back to back in one day. I mean, I've definitely
Right.
pressured myself to do it in the past, but particularly for therapy and for more difficult, like I will say, I mean, we see pretty complex patients, psychiatrically and medically, and we're often giving people some bad news, when it comes to their diagnoses with
Yes.
cognitive issues. So it's not like it does have an impact. So I'm very aware of that, and I try to create an environment and space and a support space too for to make sure the providers can come talk to me or can talk to each other when things like this are happening, because I do think it takes a toll. I think it leads to burnout. If you're not careful with overdoing this type of work that we do.
Absolutely. Yeah. Yeah. I think that gets lost sometimes, the environment and the atmosphere for providers. And it sounds like you've been really deliberate about it though, just from I think there is research around, windows are one of the like top
Yeah, I
three
mean, I'm sure there must be.
best features of a job or something, like does it have
Yeah,
windows? And that's
yeah,
highly correlated with satisfaction. So
yeah.
even simple things like that. But then the community aspect and making sure that folks have support and ability to consult or talk with one
Right.
another.
And that piece I'm trying to keep growing. I try to be really deliberate about, let's do monthly meetings, let's go have lunch, let's go be somewhere out there and get out of the space. And but I wanna that's where I want to grow. I have like this vision of like this great group of people just like, hanging out and working together, and just able to consult with each other, not in like a strictly professional way, but like in a really authentic way. Like, hey, that really hit me hard today, or I need to process this. And again, I guess that's where the therapy first comes in. And I do look for this when I hire. I do feel with the population that we serve, um, too strong of a diagnostic value system, I guess, doesn't always work too well in this setting. I really look for people that have kind of a therapeutic lens that they look through, and or that they start from when they work with people. Um, and yeah, that's just, I guess those are people that I connect with more easily in general. So that's probably part of it as well. I've learned a lesson, which is I try to bring people to the team. And this might sound kind of selfish, but I try to really see, do I connect with them? And that's one of my kind of pillars for deciding, is this person a good fit? There's others, but I find that that always works better. Like, do we vibe? Do we connect? Because if we do, we're probably going to be a good fit in this atmosphere. So
Yeah, yeah. Well, it's funny you say that. I don't know if it's selfish or what, but I mean, I do the same thing. That was always, I mean, before I really knew what my metrics for hiring were, that was the original
that's
metric
good to
was
know. I missed that
absolutely.
initially. I would just look at like competencies. I totally disregarded that. Honestly, I was just like, well, that doesn't matter. I'm looking for this, and that. And I sort of had to reverse and say, no, it does matter. It's a really good way to gauge where a person's at.
I agree. No, I agree. And I would imagine, just building a team around it with you or the owner, as sort of the hub in the middle. If everybody kind of gets along with you pretty well in different iterations, they'll probably
Right.
get along with each other too. And then it just
Exactly.
contributes to,
Yeah.
yeah, a better
That's the
atmosphere.
goal.
Right, right. For sure. So We're sort of dipping our toe into the hiring and recruiting process, which I think is hard
Yeah,
for a lot of folks right now. There seem to be a lack of
it is so
neuropsychologists.
hard right now. Yeah.
Yeah. So, yeah, I'm curious just how you are finding folks, if it's again deliberate or like them coming to you,
Yeah.
or how what
I got
recruiting
really
looks like for
lucky
you.
with quite a few, and I just think that it's done. The luck is over. I can't keep counting on like my network. But that's where I'm the most comfortable. I love that I had a lot of people that I knew through my network, or someone that I really trust. Having so that's how it worked for me in the beginning. And if I want to keep growing, I need to branch out. So, and I'm not as comfortable in that. I really like the idea of knowing the person. As my practice has kind of gone on, I've gotten a little less, you know, protective in that way, or maybe have like loosened up some of my anxiety about who comes in. And I've just accepted that I have to open this up a little more if I want to create that kind of team that I want. I can't be so like, I have to know who you are personally. So it's, and I am more comfortable with that now. But I'd say in the beginning, I was really just wanted to have people that are strictly part of my network, and that worked out. But I will say, like, it's just harder now if I want to keep growing. um Something that I do, I'm not sure what this is about, but I do have like an affinity for providing an opportunity for like new graduates like coming into the field.
Uh-huh.
um Maybe I'm not that far away. I mean, it's been a while, honestly, now that I think of it, but I still feel close to that time in my life. But yeah, I feel I think there's a bit of a interest, or a passion I have for having people come after postdoc to have like a space that they can have this type of experience. So I do end up recruiting, or trying to recruit at least. I've been trying to set up meetings with sites that do postdoc training for neuropsychs, or even just grad programs, like you know alumni and things like that. So that's been kind of my technique in the past. But even still, I feel like this need to really branch out and just um, who's out there.
Yeah, yeah, no, that's fair. That's fair. I think I've gone through a similar process. Yeah. I wonder about the interviewing process once you get in front of people or they get in front of you. You mentioned the kind of the vibe check, which is great. Are there other things like knowing that you work with older adults that you're kind of looking for, either personality wise or I don't know, ways you structure the interview to sort of gauge individuals' ability to work with that population specifically?
Yeah. Yeah, I mean, yeah, the vibe test is a big one. But yeah, definitely. I really like to use vignettes. I hated when people did this to me when I interviewed,
Of course.
but
Yeah. You're the
like, I
worst.
think it is really, I think it does have, I think it has utility for sure, especially with some of
Hmm.
these. I just have these like very common older adult situations that come up, and have come up with people that work with me, and I've seen people respond to them in very different ways. So that's where I like to use that to ask people, what would you do if this happened, or what would you do if that happened? So, and
Hmm.
it's not even as important to me necessarily. I mean, the answer does matter, but um, just gauging like how they respond, right? I always
Hmm.
find that I look for, are they exuding warmth in whatever interaction that they're talking about with this vignette? Um, if I notice more of a coldness, or too much directiveness, like, well, we have to do this now, or we have to get this done because you need this testing if I notice too much of this like rigidity to like get the work done
Hmm.
before really being with the person, making sure they understand why they're there, being flexible and saying, I want to work with you. If we can't do this today, I can have you come back, or let's do a little bit today, and then we can reschedule and get you in for more later if you're too tired. So there's just so many of these situations that come up, and I've noticed when people have a more rigid approach, it just never goes well. The person gets upset, especially if we are dealing with some dementia. There's a lot of agitation that'll come up. So I think you have to be like very good at de-escalation to work with adults that are have dementia, or just in that spectrum. If you're not good with de-escalation, you're not going to do well with that work.
Sure,
So that's
sure.
something I really look for. But I'd say just flexibility is a word. I even have it in my like values for my
Mm,
flexibility is just so important to me. Like, are you a flexible person? Do you like flexibility in your life? Just the way the clinic is structured for providers, I'm really passionate about. I want you to tell me when you want to see clients, what times work for you, how many do you want to see a week. I want people to control this for themselves. I don't care where you write your reports. It's, do it wherever you want to do it. And that's my vibe. But it's also, I want that in the clinical realm as well. So, worst case, if this patient's just not there, you have to let it go, or we have to be flexible about this and not get so rigid that you have to get this done today.
I think that's a great point. It's a great point. I mean, it works. Gosh, we work with kids. It feels
Very
pretty
similar.
relevant there too.
Yeah.
You just have to be flexible.
You have to.
Another thing that we have found is, and I'm curious about your experience here. I don't know what your admin team looks like, but this is, we've really had to recalibrate maybe our admin team as well, because we found that older adults need just like more time on the phone, and they want
Yeah.
us to mail paperwork instead of sending it over email or
Right.
electronically. And they, yeah, just personality wise, need a lot more warmth, support, like flexibility. And so we're finding it on that side of things too. So I wonder if that's come up in your
Oh my
practice.
gosh, I can't even. I've gone through so many admin. And yeah, it's just that patience is
Hmm.
so important, to be a patient person and to be flexible and go with the flow. And I have a great admin right now. And I get such good feedback because she's very warm, very
Hmm.
patient.
Hmm.
Um, and yes, I mean, do we push for getting people to do the forms online 100%? I mean, I was telling you before, I use intake queue. It's a very simple process. So sometimes what we'll do is we'll really, if the person's struggling with it, we'll at least first ask, do you have someone that can just help you try to do this? Because it's going to be easier for you to do this now online. If I send you the paperwork, you're going to be more overwhelmed with the
Hmm.
amount of pages you're going to see. It just doesn't look as
That's
long
fair.
when,
Yeah.
or and we do encourage, like, as a last resort, just once they come to the office, we have a nice space set up for that purpose, like a little sitting area with a desk and a pencil and a pen for people to just sit and comfortably do the intake paperwork. Because yeah, it happens often enough that we just have to accept it. Another one is, we do often, just with payment stuff, we try to get like insurance cards, a credit card on file prior, and that just sometimes doesn't happen. And I've had staff that were just so rigid about this. We're like, well, we can't book
Hmm.
you if you can't. And I'm like, we don't need to do that. Like, just let it go.
Hmm.
They'll come in. Once I explain it to them in person, they're not going to be afraid of it anymore. It's just, there's some, we just have to accept that there's this generational difference around
Hmm.
trusting technology. And so,
I'm so glad you um, touched on that. We have a lot, not a lot. I mean, but a substantial portion of our older adults are very cautious about giving us credit card information over the phone, which makes sense, right? Like there's all this information out there about older folks getting scammed and
right.
taken advantage of. But when it comes to the practice flow, I'm like, like
It
this
is.
is
It's a lot.
falling outside of our workflow, and we gotta
Mm-hmm.
figure this out. But it's just part of the
Yeah,
deal.
it is. And if you create a thing about it, it's just you lose people, or they come in with like the wrong impression. If there's too much of this, um, it just is what it is. Like some people, if what I found honestly though with my admin right now, she is so warm and
Mm,
inviting and patient that many more patients have been completing it and have like just gone with the flow. Whereas that was not the case before, where it was maybe a little bit more pushy and we have to have this. And um, it's just made such a big difference. I've also given her more of a language for how to explain to them why we need it and what's the importance of it, and also that we're okay. You can give it when you come in, and
mhm.
just when they hear that you're not pushing them, they often are like, "Oh, fine,
Yeah.
I'll just
It's
do it."
yeah. You mentioned a lot of environmental tweaks or decisions to support your population? Are there other things that you've done with your environment, either the space or the, I don't know, the layout or even technology, or lack thereof, that you've done purposefully to kind of cater to this population?
Yeah, I mean, I like using technology as much as possible. So, like, I've been using the iPads, like Q Interactive, since that was a thing, and
Hmm.
I I like doing everything digitally. I think the big things have been just being flexible to that's just not going to happen. Everyone's not going to do it. So we just have to let that be part of the practice. And I'm always trying to find ways to just simplify it, simplify the paperwork, simplify everything, just to make it more likely that people will just do it online and go with that flow. But
Hmm.
yeah, I'd say that's I don't think I've done anything too much more special than, like I said, just having my little desk for people to do their paperwork. That's been a big one. It actually really helps.
Yeah, yeah. I mean, it's little things like that, right?
Yeah,
Just as a nod, like, hey, we were thinking of you and what you might need, and
right.
there's a space for that. Yeah, I'm with you. I'm with you. So it sounds like you mentioned trying to slow the train down at this point. So say more about that, just from a, again, business development standpoint, and what the future looks like for your practice. It seems like you've kind of mastered the launching and the growing, and now it's like, what happens next?
Yeah, I just yeah, I just felt like it just got going so fast, which is like a very good problem to have, so I can't like complain about that. But um I guess it was always just I always found myself in the struggle of like trying to get into the, and you would know about this, getting into the more creative side of like business development, but being so inundated and like having so much clinical work you're doing that it's just, and I had to accept this at some point. I always thought, oh, I could just see a client and then sit down for an hour and do this and then switch back. Like it's not that easy to switch
No.
between like those hats, right? Like it's that creative mindset. I feel like I need like to dedicate like a few days to really be in that um, mindset, to really think about like, where do I want things to go? What am I doing? Like, how am I, like, I kind of want to drive the train more instead of the train I'm just a passenger in it, which is sometimes
Mhm.
what it feels like. Um, and I could just let it be like the way it is because it's going fine, it's not, but I think I just want to control it more. I think I want to get back into having more intentionality between, building connections with providers. I I want to really build a team that is cohesive and hopefully like more long term too, that stays together and grows. I'd really like to have more of a training experience, not lower level training. I really want to keep it to like postdoc level. But I want to have like an infrastructure in place for that to happen. Um, and it's just like it's really hard to I've kind of done it, making it happen here and there, but it just feels so scrappy. I just want to really step back and do it right, I guess. So yeah, I've more recently just become very intentional about, I take like the last week of the month, I try really hard not to book clients, like really
Hmm.
really hard. I still end up doing a little bit, but I take that week and I just try to do just development. Like I just let myself think and come up with ideas and concepts and start implementing instead of pretending I'm going to do it if I don't block the time, because I just won't. It's just not possible.
It never happens. I
Nope.
know. I know the story. I know the
Yeah.
story.
And I
Yeah.
have a baby now. That probably is what pushed it. I mean, once I had my daughter, I was like, I do not have the luxury of time anymore. I used to be able to do things at night and the evening, and it just doesn't. I'm like, if I don't book it, it won't happen. And it's actually been a blessing, really positive for me to have that structure.
That's good to hear that. Yeah. It's almost like kids, especially little kids, force you to take a real close look at your schedule and make sure
Yeah.
that it's working for you.
Yeah.
Yes.
Because I think I was very much a victim of, I forget the theory that this is called, but essentially like if you have the time, any one
Mm,
task will fill and take up
hmm.
that entire time. and I know I was guilty of that. I'm like, oh, well, I have this
Hmm.
report and I have all day to do it. I just work on it all day. And it's like, you just don't have the luxury of that anymore. And you didn't need
Right.
that day to do that. So
Yeah, I'm with you. I'm with you. Yeah, I mean, this is a super common place for practice owners is yeah, how to find the time to actually do the business, to work on the
yeah.
business. Yeah.
Yeah. And I just
So,
want it to be like, I'm not even, I guess, super clear on it yet, but I'm really, I just want to really bridge the gap between the medical and mental health world.
hmm.
Um, and I feel like it's really been fun because I do feel very integrated with these medical professionals. I feel like I'm one of them. It doesn't feel like this I'm proving myself thing that I've experienced
Hmm.
when I was like in training. It's just very natural. And it feels awesome. I really want more providers to be in that world, and I've loved it. Um, and yeah, we've talked about this before. Insurance is a big struggle. It is what it is, but as much as I hate it, I still see it as such an essential piece to accessibility for
Yeah.
people. It's just that I wouldn't be seeing the people I'm seeing if I didn't take insurance. I wouldn't see the complexity, the ease of connection. Just none of that would be there. I really don't think it would if I wasn't, you know, able to take so many insurances from people. So
Sure. Sure. I want to go back and double click on that. I don't know if you use this word, imposter syndrome, but with working with the medical community, and you said it was seamless. I wonder if there was more of a process around that. Like, if you ever felt a little bit of imposter syndrome, or maybe not. I mean, I'm just curious, like how
I
how you
felt it
got
a
over that.
lot. I felt it a lot through various experiences I've had, like in just going through uh, internship, post, like all of those experiences and just jobs. Um, because I didn't feel integrated, and that is what I hated so much about those times. Like it felt like, yes, like neuropsych would come and consult with the team, but I always just felt like we were kind of on the outside. Like it just,
Hmm.
and I felt like I always had to prove myself, or the supervisor, even I had this feeling, had to sort of prove why this was important um, to the team. So I just always had this feeling of needing to justify why I was there in a
Makes
lot of
sense.
those experiences.
Yeah.
So, and yeah, that comes with that imposter syndrome. So I'm like, well, why are we here? Clearly they're fine. We don't need to be, Um,
Hmm.
but
Hmm.
it just, I don't know. I don't know how it kind of, I think it's not there anymore because I do feel so needed by these providers. Like they sort of sought me out in a way. Like I was positioning myself, but they're like, we need neuropsych, or we really need somewhere to send these patients, these psych patients. And I mean, I get all kinds of referrals. I mean, honestly, it's sad, but psych does become this like catch-all. Like if the medical side doesn't know what to do with someone, they end up sending them to psych.
Yeah.
It is what it is. But they need it. They recognize the need, which I think I haven't noticed before, or maybe it's just where I am in my professional development that it's different. But I never felt like I was trying to prove myself or
That's
prove why
fantastic.
services are needed. I think it's been very understood that it's needed.
Hmm. Hmm. Well, yeah, that goes a long way to feel needed or wanted. That
Yeah,
does a
instead of
lot.
trying to force yourself and hey, this is why you guys need psychology. It's like why were we doing this? Of course you need it, but it
Yeah. 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 Well, I don't know. From what I know of the history of neuropsychology, that is sort of baked into the history and the lineage, is like trying to prove ourselves as like a legitimate
yeah,
field, to
exactly.
neurology and other medical professions. And
Hmm.
so I
Hmm.
mean, it makes sense from that
It
perspective. It's
does.
just,
Yeah, I
yeah.
think we all carry that still, and it's yeah. I mean, I do think it's there, but it has been interesting. Just that maybe it's the team of people I've found myself with, or I mean, it still does come up here and there, of course, but overall, it's not been very present for me, that feeling, which I'm very happy about because I really just didn't like that. I didn't like that feeling. I didn't want to be in places where I had to do that. It just felt so uncomfortable. So yeah,
Yeah.
it's nice to
Yeah.
be valued, right? That's what you said, like needed or valued. It feels good.
Absolutely. Yeah. Yeah. Well, we've covered a lot of ground. I feel like we've talked about a lot of aspects of this practice and this
Yeah.
work, and I'm just really grateful to be able to have this conversation and kind of dive into the nuances of a mainly older adult neuropsych practice. So yeah, thanks for being here.
Yeah, thank you so much. This was really fun.
All right, y'all. Thank you so much for tuning into this episode. Always grateful to have you here. I hope that you take away some information that you can implement in your practice and in your life. Any resources that we mentioned during the episode will be listed in the show notes, so make sure to check those out. If you like what you hear on the podcast, I would be so grateful if you left a review on iTunes or Spotify or wherever you listen to your podcasts. And if you're a practice owner or aspiring practice owner, I'd invite you to check out the Testing Psychologist Mastermind groups. I have mastermind groups at every stage of practice development, beginner, intermediate, and advanced. We have homework, we have accountability, we have support, we have resources. These groups are amazing. We do a lot of work and a lot of connecting. If that sounds interesting to you, you can check out the details at thetestingpsychologist.com/consulting. You can sign up for a pre-group phone call and we will chat and figure out if a group could be a good fit for you. Thanks so much. The information contained in this podcast and on the Testing Psychologist website are intended for informational and educational purposes only. Nothing in this podcast or on the website is intended to be a substitute for professional psychological, psychiatric, or medical advice, diagnosis, or treatment. Please note that no doctor-patient relationship is formed here, and similarly, no supervisory or consultative relationship is formed between the host or guests of this podcast and listeners of this podcast. If you need the qualified advice of any mental health practitioner or medical provider, please seek one in your area. Similarly, if you need supervision on clinical matters, please find a supervisor with an expertise that fits your needs.